Okay, our next speaker has a very unique perspective on hydrocephalus. Dr. Kyle Gospodarek, did I get that close? Graduated from the Indiana University School of Medicine in 2016. He's currently teaching at IU School of Medicine Northwest as a lecturer in clinical medicine. And his interest in medicine and in hydrocephalus began when he was 6 years old and had a cerebral brain aneurysm that ruptured and left him with an extremely complicated case of hydrocephalus. And I have to say that Kyle has on occasion texted me or emailed me from the emergency room saying that he was bored. You had nothing to do, right? You were bored. As this is a lifelong diagnosis that requires consistent intervention, Kyle has a unique perspective, and he's going to talk about both sides of the operating table. Thank you, Kyle. Let me just make sure that your slides are up here. If you turn it up. I'm going to do it on this side of your tie, if that's okay.
Oh, yeah, absolutely.
You'll have to tell us from the back of the room if we don't have the mic just right.
Yeah, please do.
Okay, Lindsay. Smell. We don't seem to have the, oh, there we go.
All right, good deal. Thank you.
Sorry.
All right, and I apologize, my slides are a little bit out of context. Yeah, the sizes of the pictures didn't go quite as planned, but nonetheless, as Bonnie said, my name is Kyle Gospodarek. I'm an MD, but I teach as opposed to practice typically. So just a little bit about me. I did earn my medical doctorate in 2016. I'm right now working on my master's of science and education. I ended up being fascinated by the field of education and kind of coincidentally started teaching at my home campus very serendipitously. Realized I loved it. And it kind of just stuck with me since. And unfortunately, I have to say that I was wrong. And my mother, who has told me my entire life that I was going to end up being a teacher, was correct. And so I've got to give you this one. Nonetheless, also, I did earn a Bachelor of Science in Biology with a minor in Chemistry from Purdue North Central, which is up in northern Indiana in 2010. And also, as Bonnie had mentioned, I did acquire hydrocephalus at age 6 after a brain aneurysm ruptured. Excuse me. And the location of the aneurysm was my right posterior inferior cerebellar artery. And that actually does come into play in a little bit, which I'll explain why. But the subarachnoid hemorrhage that resulted from that rupture ended up leaving me with both obstructive and non-obstructive hydrocephalus, which made it extraordinarily difficult to treat well. So I've had, including the ones from last month, which was the other time I was emailing Bonnie from the neuro ICU. I've had 56 surgeries total, and 44 of those were related to hydrocephalus alone. The others were random, kind of fun stories, but that's about it. Oh, sorry. So I did want to start with going over the ventricular system in general. I know this is probably quite a bit review for most individuals, but I figure it's worth mentioning nonetheless. So we do have 4 ventricles inside our brains that are filled with cerebrospinal fluid. We have our lateral ventricles, which are the larger ones on either side, our first and second, you could say. No one can agree on which is first, which is second, so we just call them the lateral ones. Then we have our third ventricle, which is here in the middle. And then this drains out into the fourth ventricle. And that fourth ventricle has outlets which allow CSF to leave the ventricular system and enter into the subarachnoid space surrounding the brain. So although there's, in typical situations, there's free-flowing communication between those two spaces, they do have somewhat different functions. The ventricular system has structures called choroid plexus, or as I like to jokingly call it, the nephrons of the brain, because it kind of are, they kind of are rather. Whereas the outside of the brain has arachnoid granulations, which are the places where that CSF is actually reabsorbed and put back into the venous system. And so both of these were affected by my type of hydrocephalus, my hemorrhage particularly. And going on into a little more detail about obstructive versus communicating hydrocephalus. So our obstructive hydrocephalus is something that's a little more direct, easier to explain, and in, I would argue, in a lot of cases, easier to treat, at least surgically, because there is always there's typically a source that we can localize and identify where cerebrospinal fluid isn't making it past that point. And so everything proximal ends up dilating, ends up building pressure. So we typically treat that by either putting a catheter or shunt into any of those proximal spaces, typically the lateral ventricles, because as we saw, they're relatively large compared to our other options, and they are typically proximal to any blockage that does occur. The blockages will commonly occur along this long aqueduct, or sometimes in the outlets of the fourth ventricle, which was my case. Then we have non-communicating hydrocephalus, or I'm sorry, we have communicating hydrocephalus, in which case the problem isn't so much that the spaces aren't able to, or that the cerebrospinal fluid isn't able to flow from one space to another, but rather that there's either too much CSF being produced or too little being reabsorbed. A lot of times in post hemorrhagic hydrocephalus, we will see the latter of those situations occur, wherein the arachnoid granulations end up getting clogged with blood, clogged with debris, irritated, scar over, and then they aren't able to absorb that CSF as well as they should. And in those cases, it can lead to hydrocephalus that is rather difficult to treat in a lot of situations, which is why I was fascinated by Bonnie's work, because of the idea of modulating it with drugs other than acetazolamide. And so that's all I have for hydrocephalus in general. So I'll go a little bit into my specific instance. As I said before, it's rather complicated. I have been in pain in several surgeons' rears throughout my life. It's one thing I take pride in. So the subarachnoid hemorrhage that I had was quite massive. There was a lot of bleeding, a lot of blood in my subarachnoid space, which made its way throughout the ventricles to some degree, but mostly on the outside of the brain. And in doing so, it scarred up my arachnoid granulations, but it also scarred up a large portion around the foramen magnum and around the fourth ventricle. Remember, the fourth ventricle is that spot where that CSF would be allowed to leave the ventricular system and enter that subarachnoid space around the brain. In my case, it doesn't really have that opportunity. So that's how we ended up with both that communicating and non-communicating form of hydrocephalus co-occurring. Unfortunately, this did lead to longstanding hydrocephalus, which I anticipate I will have all of my life. And it also affects the treatment options in some cases, or in this case in particular, because things like endoscopic third ventriculostomies don't really work because they're only addressing one of my problems, essentially. So as I said before, the location of the rupture, the right pica, it led to the blockage of those outflows, the foramen of Luschka and Magendie. In my case, it also led to somewhat of a pseudo Chiari-1 malformation, in which case the foramen magnum itself was scarred over to such a degree that it restricted CSF movement from the brain space to the lumbar thecal sac. So because of this, I did have a propensity for developing a syrinx or syringomyelia, which is shown here. If we zoom in there, that white center, that's actually fluid, and it should be a spinal cord because that's a T2 weighted MRI. Fluid shows up white in those cases. And all of that should be filled with essentially gray. Instead, in that case in particular, the majority of my thecal sac was dominated by CSF. There was a very large dilatation within the central canal itself, which is a whole another story that I don't think we'll be able to talk about today necessarily. Also, I developed slip ventricle syndrome, and that was a result of both the type of hydrocephalus that I had and the treatment that I was undergoing, which was shunting in the lateral ventricles. If you shunt too much, the ventricles can possibly collapse in on themselves. They become very small and eventually collapse in on the shunt itself, which obstructs it as well. So that opens up a whole new can of worms, so to speak. And so it did have some other lasting impacts. The main and the reason that I'm here with a lot of issues surgically is shunting. Shunting has both been a blessing and a curse of sorts. It's the only reason I'm here, absolutely. But it's also the reason that I ended up in the operating room 44 of those times. That's an overestimation, probably 30, 35, something like that. I have absolutely spent more nights inpatient in a hospital room than I have anywhere else other than my own bed. It's weird how it becomes familiar, getting used to that feeling of sleeping in your own bed again for the first time after a long stint in the hospital. And there's nothing quite like it. Nothing I can really compare it to. It's absolutely magical. So you just kind of got to take the good where you can. And yeah, you do get bored when you're in there, especially as a kid. So they let me fish for things on, I'm still not sure exactly what I was doing there, but nonetheless, made for a fun picture. A lot of betadine. But something else that it did for me was made me very interested in the medical field in general. I half jokingly say pathologically, and you could make an argument for it being truly pathological. But I have been interested in the medical field to such a degree that I put my own health to the side sometimes, which wasn't exactly the best thing I could have done. Nonetheless, that understanding, that interest was how I essentially was trying to take control of what was occurring within me at that time. But along the way, I came to idolize a lot of my neurosurgeons, my first being Dr. Grant. I forgot to mention Dr. Bowman from Children's, that was Children's Memorial Hospital at that point. And then we have Dr. Iskander, my current neurosurgeon in Madison, Wisconsin. And then David Frim, who I will mention a little more in detail later. But he was probably the most impactful out of these. I also realized something else. Being an observant kid that had nothing but time on his hands and no smartphones. So all I had to do was think and watch and just kind of, not much really. But one thing I did notice was the importance of everyone else on the medical team. I think any good MD knows damn well that nurses do a whole lot of the heavy lifting. And we need to treat them well and treat all of our other providers well, for that matter. So this goes on to my years of medical school, because that is the other side of my story here. Not only is it the hydrocephalus, but it is the fact that I was fortunate enough to be able to get my MD. I did matriculate into medical school in 2010. I was originally in the class of 2014. Unfortunately, due to a stroke that was incurred after taking step 1 of my boards, during a posterior fossa debridement of that scar tissue that I was talking about and removal of an aneurysm clip that was MRI incompatible, I ended up having a massive stroke and waking up not being able to feel the right side of my body. For those with the medical interest, it affected only the PWC ML pathway. So my pain and temperature sensation was left intact, which is odd, but it was a very clean delineation. Nonetheless, I did end up having to move from being right-handed to left-handed, which took some time. I took a year off, during which I did a whole lot of occupational therapy and physical therapy. And as it states here, my medical issues, not just the shunt-related ones, followed me into medical school. 20 of my surgeries of all those 56 occurred during those 6 years. And one could argue it was because I probably drove myself a little too hard in those situations. But for me, it was what kept me going. And so, not a great, I don't recommend it. I'll put it that way, but I understand it. One cool thing about medical school, though, was the opportunity to meet my regional class. And so being part of the Indiana University School of Medicine, shameless plug, at the regional campus, we have these nice small class sizes. My class was 26 students, and I got to know every single one of them very well. Whether that be going out after exams or sleeping on the floor during histology, because we only had 2 weeks to learn the entirety of it. You do learn a lot about each other, and they provided an amazing support network for one, but also I had the opportunity to teach them a lot about my own ailments as they went, spanning from shunt-related ones to hernia repairs, appendectomies. I can't remember off the top of my head, but it was a neat opportunity for me. And they were able to ask me questions that they weren't able to ask typical patients, either because it would be rude to, or just pure interest, I guess. But it was fun. And I also had some really unique opportunities, one of them being during that hernia surgery. One of my upper classmates first assisted on that surgery. And then once I was able to continue on with my clinical years, I was able to rotate with with some of the surgeons that operated on me in the past. So it was really fun, to be honest. And so that picture became, call it pathognomonic for me. It was what a lot of people came to know me as, was just in a hospital gown with first aid in my lap, or another resource, but first aid was my go-to, if I'm being honest. Because it was just a nice distraction from everything. having a lifelong medical illness it's rough. It takes its toll, but having something to drive towards, which in my case was that eventual medical degree, it was a good distraction, and it allowed me to fight a little harder. But on the flip side of that, my medical situation also gave me a little bit of distraction from my studies. So whether it's healthy or not, it was effective. I mentioned here, it anchored some of the concepts being learned because I was learning about a lot of things that I knew were wrong inside of me, so to speak. And then eventually I was able to diagnose my own genetic defect, which was a variant of Marfan's, C7702, but we'll talk about that later. Most notably, I was able to answer that nagging question of why me that I always asked myself in childhood. I figured that out, so that was very gratifying. But I did have to make a career pivot. After that stroke, I was left unable to do any real surgical options or anything too clinical. It was very difficult to be able to accommodate that, I guess you could say. And so when I came to enjoy teaching as much as I did, it just seemed like a very easy transition and a very natural one. So I mentioned my medical schooling, but I did a lot of my learning as a patient. I've been a patient a heck of a lot longer than I've been a medical student or a physician for that matter. All of my doctors were great mentors. They gave me a very unique perspective on medicine, one that you might not receive as a typical patient alone or as a typical provider alone. And they helped me make sense of it all, helped me deal with the enormity. One of those docs was David Frim. He was a neurosurgeon for, a lot of my formative years. He recently passed this year, but for 20 years, he taught me, and he treated me like a resident. He taught me how to doctor early on in my career, one of the first to do so. And so he showed me what a doctor is supposed to be, how a doctor is supposed to act. But he also gave me a lot of hell too, in the best way, in the most kind-hearted way. A lot of medical students and doctors are familiar with the term pimping. He would do that mercilessly to me. One incidence of that was when I had a exaggeratedly dilated fourth ventricle and was vomiting daily in miserable shape on an exam table. He took the time to ask me what area of the brain was responsible for generating the gagging and the eventual vomiting. And luckily I was able to pull it out of somewhere because it wasn't in my actual brain space, but it was the area postrema. So thank you, Dr. Frim. And so throughout that time, I learned a lot about shunts too, a lot about hydrocephalus treatment options, essentially. And as I said before, I wouldn't be here if it weren't for them. So I have everything to thank them for, but again, they're not perfect. They cause a lot of issues. I included these pictures because my phone actually put this together on its own and assembled it like it was this fond memory, which I just thought was hilarious. But nonetheless, they were pictures of a superficial wound infection that ended up from tissue breakdown, which I'm known to break. My skin breaks down from dissolvable sutures. That's part of my FBN1 mutation. But as I mentioned here, we have several different ways that shunts can be problematic. Each one has serious consequences. And another situation that those with shunts and families of those with shunts have to consider is, what do we do if things go sideways? especially if things go sideways outside of our home environment. Can the helicopter land on the ship? Was a question that my mother asked when we were considering going on our first cruise. We had to have contingency plans. And it was accurate. We did, because if I ended up with an infection like I did a month ago, and that helicopter couldn't land, that I probably wouldn't be here talking to you today. So we do have to consider those things. And so our lives are a lot different because of it. I also did a medical mission trip to Haiti, which I still don't know how I got away with, but my parents were not the happiest about that one. But we figured it out. We figured out a way that I would be able to get to Miami in such a convenient time frame, so on and so forth. I'll leave it at that. So other than just the issues that I mentioned before, there are other morbidities. Revisions, as was mentioned, every shunt eventually fails. It's inevitable. Shunt infections occur in roughly 5% of revisions. There's a need for ICP monitoring, which is what you see here. That's a fun one. That was the first time that I emailed Bonnie from the neuro ICU, asking her if she had any work that I could do remotely. And then EVDs. You get real used to seeing your own CSF in a bag, which is kind of odd, but it happens. But it also gives us areas where we could work for improvement, right? We already talked about having shunts that would be able to clear their own blockages. That would be an incredible strain that would be taken off of hydrocephalus patients, because that would remove a lot of revisions from the situation. Also, if we were able to monitor for ICP within the device itself, it would be very helpful. Bacterial infection prophylaxis, of course, I know that comes with its own difficulties though. And then we've got more physiological means of CSF diversion, one of those being aqueductoplasty, which I learned about quite recently, but it's fascinating. So as a patient, one of the things that I have noticed as an area that we could improve is better transition from pediatric care to adult care. It's a very difficult thing for hydrocephalus patients to do that transition. And some of it's because our pediatric neurosurgeons only treat pediatrics. A lot don't. A lot will see their adult patients as well. But sometimes it's difficult to find someone that is willing to see an adult patient with hydrocephalus, because they're kind of few and far between. I shouldn't say that quite. They feel few and far between when you're looking for them, I guess. Which is something that as a provider, I think we can do better at too, is making ourselves aware or making ourselves available to those patients. So the thing that I am most excited about is the notion of our basic sciences, foundational sciences, and clinical sciences working together to actually have a better treatment option, that we might be able to meld some of our surgical maneuvers with CSF modulation in either production or absorption. Individuals who are much smarter than me in those areas, I'm going to pass that buck to, but I have faith very much that we'll get somewhere. And so as my last slide, if you do have any questions, as we mentioned before, my email is here. My cell phone is also here if you'd like text or call. Other than that, thank you for your time. And
Thank you very much, Kyle. We're now going to take a short break. We're going to stay on schedule by starting again at 3:15, because that's what